I'm Vanita Jairaj, clinical instructor with the Comprehensive Ophthalmology Service at the University of Michigan's Kellogg Eye Center. I'm discussing intraocular lens selection. When choosing the best IOL for a particular patient, there is no cookie-cutter answer. The target of uncorrected distance vision of 20/20 may not be expected, desired, or possible. So IOL selection, with the purpose of optimizing vision and achieving patient satisfaction, starts with good pre-op planning. The aim of this talk is to offer a practical, thoughtful approach to IOL selection. The optics of the human eye can be understood as a complex vergence problem with multiple refractive surfaces. First, we measure various anatomic aspects of the eye. Next, we plug these measurements into formulas that use regression analysis to adjust for the ever-so-elusive effective lens position, and these formulas then calculate IOL powers for possible refractive targets. We then choose a specific refractive target with attention to our patient's needs and desires, and finally, we select the IOL we hope will best achieve the target of optimizing the patient's vision. Modern cataract surgery has undergone rapid evolution in the last few decades, and this progress has improved our post-op refractive outcomes. Advances include more and better data with machines that obtain more accurate biometry, increased sophisticated IOL calculation formulas with better predictive power for post-op outcomes. Also, strides on the fronts of surgical technique include more astigmatically neutral wounds, and our IOL technology advancements allow options of IOL features such as asphericity, toric correction, and presbyopic correction. The goal of this talk is to discuss principles for IOL selection that minimize post-op refractive surprises. The details of advancements in various options for biometry, calculation formulas, and various surgical techniques in IOL technology are quite useful, but are beyond the scope of this talk. So our main focus here is to offer a framework for IOL selection. Here I have outlined 5 steps to think through before making your final circling and final selection on your calc sheet. Step 1 is confirming the identity of your patient and the correct laterality and the correct study and settings. This identifying data is a very easy step to do, but it's also an easy step to skip and forget. Checking and double-checking are common sense, but pressures for high volume and high-speed surgery coupled with communication error can result in implantation of the wrong IOL. This complication happens to be one of the more common malpractice claims for ophthalmology. We use different safety checkpoints to avoid this error, including marking the eye, timeouts, and having only one patient's information or IOL in the OR at a time. The starting point to verify correct information is your calc sheet. So train your brain to always first assess the identifying data before moving on to looking at the numbers. Step 2 is focusing in on your measurements. Refractive power of the eye is dependent on certain anatomic properties that include the axial length, anterior-posterior curvature of the cornea, and index of refraction of the various media that light travels through, going from air to tear to cornea, through the aqueous humor, lens, vitreous, and finally forming an image at the retina. As we've discussed, elements of the anatomy of the eye are measured and inputted into IOL calculation formulas, and then spit out an IOL power, which is anticipated to achieve the target refractive power we're looking at. SRK is not the most sophisticated IOL formula we currently have available. However, its simplicity highlights the weight and importance of measurements for good IOL selection. The SRK formula determines IOL power by taking the A constant, which is a single constant to predict IOL position, minus 2.5 times your axial length, minus 0.9 times your central corneal average power. Here we see that in an average length eye, a 1 millimeter axial length error translates to about 2.5 diopters of error in your IOL power selection. A corneal power error of 1 diopter amounts to a little under 1 diopter error in your IOL power selection. Here we understand that the axial length holds more weight than your corneal power. However, more importantly, we see that garbage in equals garbage out. To optimize IOL selection, we want reliable and valid measurements, so that we have accurate measurements and accurate IOL calculation and selection. Starting with axial length measurements, we first want to examine the quality of the chosen study. For example, if we're using an A scan, we'd take a peek at the sharpness and height of the peaks of the waveform. If we're using an IOL master, we'd also want to examine the waveform, but also pay attention to the signal-to-noise ratio. We next look at the symmetry between the two eyes. The second non-operative eye serves as a control. If the axial length measurements don't fall within 0.3 millimeters of length between the two, we'd want to ask ourselves, why not? Is it due to poor technique on the operator's part or poor fixation on the patient's part? And finally, if those aren't the factors, is there some other anatomic explanation, such as a scleral buckle, staphyloma, or perhaps just an anatomic variation, in which case we can even check the manifest refraction to see if it follows with a more myopic refraction and a longer eye. We then go on to look at the repeatability or reproducibility of one measurement for one eye. For this, we'd like to stay within 0.1 millimeters variation for the same eye. Once we are confident with the validity and reliability of a measurement, we then want to make a qualitative assessment of the length of the eye. Is this a short eye, a normal eye, or a long eye? This determination guides formula selection and also helps us anticipate a possible either hyperopic or myopic refractive surprise shift that we might expect. Finally, as one final check of making sure it all makes sense, we want to get a sense of, is the bigger picture correlating in with what we'd expect? So, for example, if it was a short eye, we'd expect a higher IOL power. If it was a long eye, we'd expect a lower IOL power. Also, if there's a true difference in the axial length between two eyes, we'd expect 1 millimeter difference in a normal eye to result in a 2.5 diopter difference between the two IOL power selections. Versus if it was a long eye, we'd expect about a 2 diopter difference between the IOL power selection between the two eyes. And finally, if it was a short eye, we'd expect about a 3 diopter difference between the IOL power selection. Moving on to keratometry, we run through a similar checklist. First up, checking the quality of the test. For example, if we're using an Atlas topography, we'd take a peek at the Myers and check at the crispness of the Myers, the centration over the pupil of the Myers, and also do other checks. Do we have any data loss from lid artifact? If our Myers are poor quality, we try to explain that. Is it that there's poor tear film quality? Are we out of focus? Or is there perhaps some underlying ABMD? Once we are confident with our quality check, we then move on to taking a peek at the symmetry. We want to take a peek at symmetry of average of powers as well as the level of astigmatism. We'd also like to make sure that the axis makes sense. For example, we typically would expect an enantiomer or mirror-like formation of the axis for astigmatism. So, two eyes would typically have both with the rule astigmatism or against the rule astigmatism, or if we have oblique astigmatism, we'd expect a mirror-like formation of 30 and 150. So, for these markers of astigmatism in particular, they're very important when you're correcting for astigmatism with either a toric IOL or with an LRI. You want to do multiple checks for consistency to make sure your data is reproducible. You can take your manifest refraction, your case from your IOL master, and cross-check that with your topography. In the same vein, you also want to use your topography to guide you for any sort of astigmatism correction to first make sure you don't have any sort of irregular astigmatism, and this can also help parse out whether your astigmatism in your refraction is from a corneal or lenticular etiology. Step number 3, our eyes are designed and created as a binocular visual system. So let's not forget the fellow eye. Considering the past and potential future of the fellow eye is important to IOL selection of the operative eye. The first thing we assess is the lens static. Is it a phakic eye, pseudophakic eye, or an aphakic eye? If the eye is phakic, does the eye need to be scheduled for cataract surgery as well? Is it a visually significant cataract? Or is it an incipient cataract and we don't anticipate surgery for another few years? These sorts of judgment calls are really quite important for the final IOL selection, as there are considerations such as anisometropia and also informing and keeping the patient counseled as to what to expect post-operatively. Will they need something like a contact lens to avoid asthenopia, or are they really anticipating having both eyes done in a month? If the fellow eye is pseudophakic, we have other things to check for. For example, we'd want to know what is the color of the intraocular lens implant in the fellow eye, what was the actual target for refraction, in that eye, and finally, what was the end manifest refraction in that eye and error from the first target that was chosen. These sorts of pieces of information help us to also guide the operative eye because some patients do notice a difference in color of IOL selection between the two eyes. Or if we do know that we did not hit our target in the first eye, and we do see that there was a good bit of error, we can use that amount of error to adjust for the calculation in our next eye. Step number 4, special circumstances. One size does not fit all. Here we want to pay attention to the bigger picture and the context of what we're looking at. We've already gone through one case example, which is the length of the eyes. Certain extremes of axial length can give you certain anticipated refractive post-op errors. For example, a long eye, we expect a hyperopic error. In a short eye, we expect a myopic error. And there we can make certain adjustments. Other sort of special features to consider are if the eye has silicone oil, do we anticipate a silicone oil removal? If not, we might want to choose a PMMA IOL rather than a silicone IOL. And then there's, of course, other features as far as the index of refraction that also are quite important for a silicone oil-filled eye. Other special features include eyes post-LASIK or PRK, where we might anticipate having difficulty measuring the true corneal power and anticipate an hyperopic error. Or patients who have things like Fuchs dystrophy and have perhaps anticipated DSEC corneal transplant in the future. For those patients, we might want to have a more myopic target than otherwise. Finally, in a talk about IOL selection, let's talk about the refractive target. There are 3 key guiding principles here to pay attention to. Of course, there's the patient's preferences and needs. And with attention to that, we would want to have a very thorough preoperative discussion as far as does the patient want both eyes at distant targets with monofocal IOLs, near targets with monofocal IOLs, monovision, or would they opt for a premium IOL with either a multifocal or a toric or some other sort of presbyopic correction. Next, we tend to err toward myopia. Myopia is better than hyperopia if your calculations are off. Finally, we have to take into consideration any sort of intraoperative events. IOL position, of course, does determine the power selection as well. So if there's an intraoperative complication, we would also want to have a backup IOL calculation as far as a position, whether it goes in the bag, in the sulcus, or in the anterior chamber. Let's try to take our systematic approach and apply it to our case example here. Our case example here is the case of Mr. Lon, 50-year-old gentleman with painless progressive loss of vision over the course of a year. His past ocular history is remarkable for an RD, that is status post-vitrectomy and buccal repair in that right eye, and he's also had some laser barricade in the fellow eye due to lattice. If we take a peek at our best corrected visual acuity on the manifest, we see he has a best corrected visual acuity of 20/50 in the right eye, with a spherical equivalent around -14, and best correcting to 20/20 in the left eye, and a refraction around -10. Slit lamp examination is remarkable for a 3+ NSC with trace PSC in the right eye, and a 1+ NSC in the left eye. Dilated exam shows what we'd expect, surgically absent vitreous, as well as a medium-height scleral buckle and some chorioretinal scar on the periphery, but the retina is flat. And our fellow eye is also fairly within normal limits and a bit of laser barricade around that lattice. Before moving on to the actual calc sheet, we want to just take in the patient scenario and see if all of it really makes sense to us. We should already be thinking about why things are what they are. So, for example, if we take the manifest refraction, we right off see that the right eye is about 4 diopters more myopic than the left eye, -14 versus -10. We'd want to be thinking, why is that? Is there an underlying cause or reason for that? Is it maybe the scleral buckle that explains why that right eye is more myopic? Or perhaps it's the nuclear sclerotic cataract that's created a myopic shift. Or finally, maybe it's a really true anatomic difference, in which case we might think, okay, the vision potential might be limited in that right eye, not only from the retinal detachment, but also potentially from amblyopia from having such a significant difference in an axial length. These can all be quite helpful in informing the patient for kind of expectations post-operatively. Now, when we take in this situation, we also want to ask the patient their needs and desires at this point and also give them some information of what they could expect with their different options. So in this case, Mr. Lon, we see has only a visually significant cataract in the right eye. His left eye is seeing 20/20 and not much of a cataract there, and so there's not a need necessarily to proceed with cataract surgery in both eyes. In this situation, if we were to do cataract surgery only in the right eye, right off the bat we'd see we could potentially leave him with a very, very high degree of anisymmetropia. So at this point we'd want to counsel him about, he may want or need a contact lens post-operatively if he does want us to shoot for a plano target in that right eye. And alternatively, if he really doesn't tolerate contacts, doesn't want to wear a contact, and really isn't bothered by his glasses, we might even choose a -10. It really is kind of laying out the options for him and seeing what it is he wants after the surgery. So, in this case, Mr. Lon is familiar with contacts, is a contact lens wearer, and chooses to have distance correction with a monofocal lens in the right eye. So let's proceed to taking a peek at his calculation sheet. Here we pull up IOL Master calculation readout. And it's tempting, since we already know what our target is, we know that he wants a distance correction, it's tempting to look right at the numbers and say, okay, let's shoot for plano, maybe a 20.5 diopter lens here. However, that's kind of not taking into account our framework, which we've just discussed. And we'll see that doing that can be a problem. So if we mag up on that same IOL Master readout and kind of take a step-by-step approach, we see our first step is to look at the identifying data. Here we see we've actually got the incorrect patient. This is not Mr. Lon, this is Mr. Hodge. And there are many checkpoints for where you can get a wrong intraocular lens sheet put in your paper chart, scanned into your computer record, or even if over turnover, one chart's not removed and another chart gets placed into your room, if you grab the chart and look just at the numbers, you can have a wrong implant very easily. So first step, identifying the data. Patient name. And here is another clue. We were just talking about a very long eye. If we had paused, we'd say, okay, this axial length doesn't even make any sense. If we have a refraction of -14, I really don't expect a normal axial length like 24 millimeters. We'd expect it to be quite a bit longer than that. All right, so take 2 here, and moving on to our actual correct calculation sheet. And still starting off with our first step, identifying the patient's data. We start with patient name, correct patient name, correct eye, laterality check. And here we see that the axial length does make sense, at 27.84 millimeter eye. That does hold true with what we were saying before. Our next step here is testing the quality of the study. So we have an IOL Master. We want to look at the signal-to-noise ratio. We'll talk a bit more about this when we come to the second sheet of this handout, because that's where we get a bit more information as far as the waveform and also a spread of signal-noise ratio. But here we have a fairly reliable study, as we can then see with looking at symmetry between the 2 eyes. We have the right eye and the left eye, and we see both fall at about 27.8, so symmetry check is done as well. If we then move on to looking at the keratometry for symmetry check, we see that also is okay, roughly about 43.5 diopters. We're falling within our mark of 1 diopter. And although the axis is not really quite following the enantiomer discussion we discussed, here we don't really have a very high level of astigmatism, and we're also not correcting for astigmatism, so we can kind of overlook that at the moment. Moving on to the second sheet of our IOL Master calculation, here we can get into more in-depth discussion of the quality of the study. If we magnify up, we see the blue arrows here showing us the waveform. Here we have a nice spike. We see these tiny little wavelets that flank the one nice high spike, and that's showing us a good waveform. If we then look at the signal-to-noise ratio, we've got multiple readouts for each eye. So our axial lengths are once again showing symmetry between the 2 eyes. And if we look at the signal-to-noise ratio, we see that both groupings are well above 2, which is a good sign for a good study, good quality study. If we look at the spread of readouts, we also see that we have a very tight grouping. So we're getting highly reproducible, highly reliable data for both sets of readings here. Now that we've assessed the validity and reliability of our measurements, we then go on to make the qualitative assessment of our axial length. In this case, we've already discussed a bit that it is a long eye at 27.8 millimeters. And the main takeaway here is to make that assessment and anticipate what sort of formula you want to use or what sort of error you'd expect because of the length of the eye. In this case, with a long eye, I expect a hyperoptic surprise, and there's a number of ways to deal with it. You could either shoot for a more moderately myopic target, or you can perhaps choose to use the SRK formula, as that's a bit better with longer eyes. In this particular case example, I choose to use the technique offered by the Wang and Koch group out of Baylor, which is adjusting the axial length using their formula. So here I am using the Holiday formula, but before making that adjustment in the axial length, I'd like to show you what would happen if I didn't make this qualitative assessment and adjust for it. If we took just this readout from here, and I'm aiming for a plano target as Mr. Lon wants me to, we'd choose an 8 diopter lens implant. Now moving on with the adjustment, once again, I'm still using the Holiday formula, but I've made the adjustment in the axial length. So going from 27.8, that adjustment by Koch and Wang gives me a 27.34 millimeter adjustment. And in this case, with an SN60WF IOL, I see that they recommend a 9.5 diopter IOL. That's a 1.5 diopter difference for error. So the main thing is that once you do have that axial length, make the qualitative assessment because it can give you quite a different choice in your IOL power selection. Here, we then move on to that final point which I discussed is intraoperative surprises. We want a backup lens selected because in case we move from an in-the-bag case to a sulcus case to an ACIOL case, we want to be able to predict that shift in power needed based on the IOL position in the eye. So for the MA60AC, depending on if you do optic capture or not, you want to have 2 choices. And then also for your MTA4UO, you want to have a choice there that will help you anticipate what you want. Here to give a little bit of a wrap-up on our real-time case, at post-op month 1, we had an uncorrected visual acuity of 20/20 in that right eye. As expected, we had marked anisometropia. In that left eye, we still have out refraction of -10, and our patient, as anticipated, went on to use 1 contact in his left eye and used over-the-counter readers and was quite satisfied with that outcome. In summary, the following are the main components of a systematic approach to direct your intraocular lens selection. First, reviewing the identifying data. When reviewing your calc sheet, this means correct patient, correct eye, correct study, correct settings. Check your measurements. Even if you pick the perfect IOL formula, it is only as good as the inputted data. Garbage in, garbage out. Pay attention to the details of your chosen studies using multiple quality checks for validity, reliability, and ultimately accuracy of your measurements. Pay attention to the fact that you are working with a binocular visual system. The fellow eye status does matter, particularly to the patient, for what they would expect for their vision post-operatively. Pay attention to the bigger picture for context or any sort of special circumstances that may guide your IOL selection, as we discussed. Is this a silicone IOL filled eye? Is it post-LASIK? Or is it a really long or short eye? And finally, talk to your patient about their needs, desires, and reasonable expectations. There's certainly been tremendous evolution as far as cataract surgery, and with that we've also had evolution to higher patient expectations. One of my attendings from training joked that patients would like surgical results that are painless, perfect, yesterday, and free. While such expectations may not be achieved, approaching IOL selection with a systematic, thoughtful framework can minimize your post-op refractive surprises. And a careful approach coupled with good pre-op counseling can help you result in achieving the target of a much happier patient. Thank you for your time and attention.